Hello.
Shall we start, sir?
Yeah. Madam has come, no?
Yes,
Yeah,
ma'am has
yeah.
come.
Good afternoon.
Madam, good evening, madam. Good evening,
Sudhakar.
madam.
Yeah, good evening. I'm here.
Yeah.
Good evening, Sudhakar. Yeah. Nice seeing
Yeah,
you all.
good evening.
So we'll start,
Yeah.
ma'am. We'll start.
Yeah, sure.
Good evening, everybody. Team IAP CCB 2026 is proud to present the second session of the recent updates in pediatric education. The last session, the first session is still fresh in our memory. I think the rendezvous with the SBS sir and Dr. Ramanan is still fresh. Moving on today, we have two interesting topics: chronic abdominal pain and constipation. Now, the beauty is, it looks seemingly simple, deceptively simple, but it comes with complex connotations. And that is the pure genius of today's session. And we are very happy that these sessions are being convened by our very own SBS sir, and we have expert mentors for every session. And I would request Sudhakar sir to introduce the mentor for today's session, Dr. Sumati ma'am. Over to Sudhakar sir.
Good evening to every one of you. It is my great privilege and honor to welcome our esteemed mentor, Dr. Sumati, a distinguished pediatric gastroenterologist, head of the Department of Pediatric Gastroenterology, Institute of Child Health. And we all know, madam, she's such a simple and humble person but rich in knowledge. She never hesitated to give any opinion at any time. No? You can easily approachable person. And we all know about madam's clinical expertise, commitment to patient care, and really her contribution to this specialty have inspired many professionals in the field. Her guidance, experience, and academic continue to shape better outcomes for children with these conditions. We are extremely fortunate to have such an accomplished mentor and leader chairing this session today. And I'm confident that her valuable perspectives and moderation will greatly enrich the discussions and learning for all of us. On behalf of the Indian Academy of Pediatric Chennai City Branch and my team members, I extend a very warm welcome to Dr. Sumati and express our sincere gratitude for taking time to chair this session. Thank you, and we look forward and engaging in insightful discussion under your chairman. And here I'd like to mention that due to prior commitment for another educational program in Mumbai, Dr. FPSR is not able to join us, very unfortunate. But we have to thank Sir for his continued support for our recent updates in pediatric education and a new initiative by Indian Academy of Pediatrics of creating a wave of creating the interest among the postgraduates in the recent updates as well as the practitioners. And thank you on behalf of IAP. Madam, it's up. Now it's your session. Please carry on, madam.
Thank you, Dr. Sudhakar, for your nice introduction. Actually, I should thank you for giving the opportunity. And the students are always my close to heart. So I think will try our level best to make the students understand what is a pathology and what are as a clinicians, what they should know. And there are recent advances and which can be practically, whether it is feasible in practice and in theory, is I think I would like to go into the subject. And let us take the forward. I think the students can take up the session because you can finish it on time. Thank you, Dr. Sudhakar, once again.
Yes.
I'll try my level best.
Thank you. Usually we don't talk much about in these things actually. Rupa is very concise directly to the subject. Thank you, madam.
Sure.
Thank you.
Thank you. Thank you.
Thank you so much, ma'am. Today's presenters, we have Dr. Arivalagan from Coimbatore Medical College, Dr. Raja Karthika from Tanjavur Medical College, Dr. Vishnu Priya from Mehta Hospitals, and Dr. Niveda from Government Mohan Kumaramangalam College, Salem. So we have 4 presenters today. We will have 2 presenters for each topic. The first of which we will begin with chronic abdominal pain. May I request Dr. Arivalagan? to start his presentation on, the practice essentials, because everything begins with terminology, definitions, epidemiology, pathogenesis. So over to Dr. Arivaragan.
Yeah, yes, ma'am. Good evening, ma'am. Good evening, ma'am. Is it visible, ma'am?
Yes, yeah. Slides are visible. You proceed, yeah.
Good evening, everyone. I am Dr. Arivaragan, final year postgraduate in Coimbatore Medical College and Hospital. I am going to discuss about chronic abdominal pain, etiology and pathogenesis, and what is the recent name given to for the chronic abdominal pain. Moving on to the slides. First, what says the chronic primary pain? Chronic primary pain, rather than it can be an abdominal pain or any other pain, but we are naming as a chronic primary pain, is defined as a pain in one or more anatomical regions that persists or recurs for longer than 3 months and is associated with significant emotional distress and significant functional disability. Here we are quoting it as with an emotional distress and significant functional disability, and that cannot be better explained by another chronic pain condition. So here chronic abdominal pain is defined as a chronic or recurrent abdominal pain that lasts for more than 3 months. So what is the main motto is we have to make pain matter, make pain understood, make pain visible, and make pain better. So moving on to the definition, our main point of interest is functional abdominal pain according to the Room 4 criteria. It comes under 4 subclassifications: abdominal migraine, functional abdominal pain, and functional dyspepsia and irritable bowel syndrome. Whereas in functional and abdominal migraine, any diffuse pain lasting longer than an hour with daily activity interfering with daily activities, at least 2 episodes over a period of 6 months, and pain accompanied by 2 or more additional symptoms like photophobia, nausea, vomiting. Whereas for functional dyspepsia, postprandial fullness or early satiety with epigastric discomfort or burning that was not brought by or interfere with defecation, occurring at least a few days each month for at least 2 months. Whereas IBS, the same definition follows, associated with 4 days a month for at least 2 months, connected to bowel movements, whether it will be associated with frequency or consistency of fecus, and persists even after the constipation in children. Coming to the last, functional abdominal pain, not otherwise specified, is the most common. So it will not fulfill the criteria of abdominal migraine or functional dyspepsia and irritable bowel syndrome, whereas occurs at least 4 times per month for at least 2 months, involve episodic or persistent stomach pain unrelated to eating or menstruation. So why it is important here? Going on to the red flags on history, what is the main emergency is any pain away from umbilicus. So according to the Apley's rule, pain towards the umbilicus is more towards functional, and pain away from the umbilicus we should rule out the organic cause, and pain awakening the sleep or pain with changes in the bowel habits associated with any rashes, any dysuria or arthritis or other constitutional symptoms including a persistent fever, lethargy, loss of appetite. Red flags on physical examination: child with growth retardation or failure to thrive with orgonomegaly or localized abdominal tenderness away from the umbilicus, any joint swelling with warmth or tenderness with associated with hematological abnormality like pallor and anatomical abnormalities like abdominal hernias. So what is the etiology for the chronic abdominal pain? More towards functional bowel disorders, irritable bowel syndrome, functional dyspepsia, abdominal migraine, constipation, mesenteric adenitis, urinary tract infection, lactose intolerance. Here we mainly concentrate about functional abdominal pain disorder related to functional dyspepsia, abdominal migraine. RAP, recurrent abdominal pain, the same thing follows. Here, irritable bowel syndrome, it will follow inflammatory bowel disease or any stones or any abdominal tumors. In child, pancreas inflammation related to scorpion bite or any stomach ulcers due to chronic steroid use and NSH use. With sickle cell disease following a so aerophagia or bizarre or abdominal tuberculosis. Regarding the prevalence, not only abdominal pain, any chronic pain in the worldwide, 1 in 5 children have a chronic pain. More towards South America, it's 16.8%, and Asia 16.5%, and Euro 10.5%. This is the latest from 2000. And among the functional abdominal pain, not otherwise specified, is the most common entity. So the prevalence of functional abdominal pain is more than 13 to 13.5% in the age group of 4 to 18 is the school-going children, where we may have school absentees are there with more preponderance over girls over boys. Coming to the functional abdominal pain disorder, according to the Rome criteria 4, so it is subclassified into 4. Whether I'm able to hear me?
Dr. Arivaragan, your screen sharing.
Yeah,
one
screen.
second,
start.
it's disconnected. One second. Is it visible
Yes,
now?
you're back. You're back.
Yes.
Yeah. So, coming to the functional abdominal pain disorder, according to the Rome 4 criteria, it is subclassified into 4 types: functional dyspepsia, irritable bowel syndrome, irritable bowel syndrome, abdominal migraine, and functional abdominal pain not otherwise specified. Where functional dyspepsia is delayed in gastric motility, delayed gastric emptying, or short relaxation of postprandial, and irritable bowel syndrome, where the child mainly complains regarding the associated with the defecation problems, where the child will urge to poop, or symptoms will get worsen after pooping, or symptoms get relieved after pooping, and it will be associated with stool frequency, whether it is associated with constipation or it will be associated with diarrhea. And abdominal migraine, main thing, it will be associated with other symptoms like nausea, headache, and vomiting. And functional abdominal pain not otherwise specified, it will not be fitting into the above 3 criteria. So that is the latest criteria for the functional abdominal pain. All of the following criteria must be met with symptoms onset at least 6 months prior to the diagnosis, coming to continuous or almost continuous abdominal pain, no relation to any physiological events, or there will be some loss of daily functioning in like absenteeism in school, and the pain is real or not feigned, insufficient symptoms to meet the criteria for another functional gastrointestinal disorder. So these 4 subclassified categories should be met into these criteria. So regarding the pathogenesis, there is a normal visceral pain transduction. The main pathogen is follows peripheral sensitization of visceral afferents, or central sensitization of spinal dorsal horn, or descending modulation of the nociceptive pathways. What this is, there will be normal visceral pain transduction from the afferent pathways from the gut to the brain. Peripheral sensitization means persistent inflammatory infiltrates in the gut due to any stresses like inflammation, or due to any emotional stress or any psychological stress. There will be increase in frequency and amplitude of pain signals. So there will be a peripheral hyperalgesia, followed by receival of volume of signals, more number of volume of signals to central sensitization. It causes increased pain, and descending modulation through cingulate cortex. It will also modulating the pain pathway. So functional abdominal pain not otherwise specified is more towards descending modulation of nociceptive pathways, and irritable bowel syndrome is more towards peripheral sensitization regarding the post-infectious IBS. So I will show some picture. So this is the whole pathogenesis. The 3 main things: visual hypersensitivity and central hypervigilance and disruption of microbiota gut-brain axis. First thing is early life events, starting from the neonate, early exposure to pain like nasogastric suctioning while a newborn resuscitation, or any gastric surgery with stress, or early traumatic events like maternal psychological distress, or psychological or physical or sexual abuse and parental loss. Another thing is early dysbiosis regarding starting from the mode of delivery, whether it be a vaginal birth versus cesarean section, or diet, breastfeeding versus formula feed, or any medication use of antibiotics and proton pump inhibitors, and other anatomical defects like poor gastric emptying or poor antral motility and abnormal gastric myelolytic activity, and early introduction of cow milk protein hypersensitivity, pyloric stenosis. So what this is, these disorders have historically been described as functional. Now they are considered as disorders of gut-brain interaction, DGBI, emphasizing that the term functional should not be misconstrued to imply a non-organic condition. So another thing before this is gut-brain axis interaction. Now they have added on the data microbiota gut-brain interaction. So the main thing is the pain should be at least for 3 months and should be not be an organic cause. These are my references.
Thank you, Dr. Arivaragan. So yes, nicely mentioned. There is a change. First, previously we were talking about recurrent abdominal pain. Can I just talk for after each person?
Yes, ma'am. Your expert comments are awaited. Yes, ma'am.
So
Absolutely.
the chronic abdominal pain has now it has replaced. No, earlier the RAP has been replaced with chronic abdominal pain. The pain should be there for at least 3 months, and now it is no longer classified as a gut. It's a disorder of brain-gut interaction. We don't say just it's a case of dysfunctional pain or a psychogenic pain. there is a component of your disordered brain-gut interaction resulting in various types of pain. Now, as I mentioned, the 4 types of functional dyspepsia, migraine, functional abdominal pain, IBS, and not specified as well. And IBS, we have to think whether it is due to an IBS diarrhea predominant or a constipation predominant, or it's a pain predominant type of IBS, or it's a mixed component. Okay, and as you rightly mentioned, it doesn't mean that as a child grows, the stress comes only the later part of the life. As you said, the stress can be even at the neonatal period. Any stress starting from early in life can have a role in this disorder of brain gut interaction, and as you said, even the gut dysbiosis. So, the acquisition of the microbiota, that depends upon the type of your delivery, usually the breastfed, the non-breastfed, and the maternal flora has an implication on the acquisition of the microbes of the gut in any infant. So all these play an important role. So even we say it is only functional, even the inflammation of the gut can result in the alteration of the pain perception, altered gut motility, altered gut even pain, what do you call that? No, visual hypersensitivity. So the pain will be there, that it depends how a person react to that. So any change in the coping of a lifestyle event or a stressful event anytime during the lifetime will modulate the pain perception that can result in what is called as a DGBI. So a lot of emphasis now is put on that gut dysbiosis as well. And there are various studies what's the role of probiotics, but we don't generally use probiotics because the prevalence of pain also depends upon the many other factors, the epidemiological factors, the food habits in the culture, the customs, whatever. It differs from one country to another country. But basically the gut has got a great influence on the all your DGBI, whatever the disorders as he mentioned. So remember the CAP, chronic abdominal pain, the Rome criterion, what are the different types, what is the role of your pain at the early onset, and the gut dysbiosis. And I think we have to do more studies on the gut dysbiosis in infant and young children, those are having this chronic abdominal pain syndrome. Thank you, doctor, for a nice presentation actually. Next, I think the next speaker can go on that.
Thank you.
So, good evening, everyone. I'm Dr. Raja Karthika, second year pediatric student from Tanjore Medical College. My topic for tonight is recent advances in the evaluation and management of chronic abdominal. Can we move to the 8th slide because everything is already discussed?
Yeah.
Yes. So, no, the before slide. Yeah, so these are the most important 3 concepts that are mainly discussed in the recent advances. Earlier, actually, the functional abdominal pain was thought to be mainly of more psychological. However, the recent advances shows that it is actually a disorder of gut-brain interaction. The brain and the intestine communicate continuously through neural, hormonal, and immune pathways. When this communication becomes abnormal, normal gut sensation are usually perceived as pain. The second concept is visceral hypersensitivity. One of the major advances in understanding in this concept is that intestinal nerves become more sensitive so that even normal physiological events such as gas or intestinal stretching are perceived as painful. The third most important recent advance is the microbiome research. The research shows that the intestine contains trillions of microorganisms collectively called as gut microbiome. These microbiomes influence intestinal motility, immune responses, intestinal permeability, and pain signaling. Studies have shown that altered gut microbiota composition can lead to increased fermentation, excess gas production, intestinal inflammation. So that microbiome targeted therapies has come up with probiotics. Probiotics are nothing but beneficial bacteria that improve microbial balance, which, for example, lactobacillus and bifidobacterium. And prebiotics are nothing but dietary fibers that stimulate the growth of beneficial bacteria, which include inulin and fructooligosaccharides, and symbiotics, which is nothing but the combination of probiotics and prebiotics. Future therapies include like a microbiome modulation and fecal microbiota transplantation. So usually we do investigations such as CBC, ESR, CRP, urine analysis to look for any urinary tract infection, kidney stones or hematuria, and stool examination to look for parasites or occult blood. But in recent advances, they also suggest to include celiac screening and fecal calprotectin include in initial investigations, because celiac screening it actually involves the testing of tissue transglutaminase antibodies. Why it is actually done is that celiac disease is a common cause of chronic abdominal pain. Symptoms may include like abdominal pain, diarrhea, growth failure, and anemia. Early detection can prevent malnutrition and long-term complications. Whereas fecal calprotectin is a stool marker of intestinal inflammation, it is usually released during intestinal inflammation from neutrophils. It can help us to differentiate between functional abdominal pain and inflammatory bowel disease. Next slide. So in lifestyle changes, we usually give general advice, but we do not more stress about the regular meals, adequate sleep, regular physical activity. We also encourage school students to attend schools regularly, even there is abdominal pain, and stress management is given through various techniques, which will be discussed in the upcoming slides. The earlier we used the dietary management was mainly of avoiding lactose and increasing fiber-rich diet. But the current study shows that introduction of low FODMAP diet. FODMAP actually stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. These carbohydrates are poorly absorbed in the intestine, and they draw water into the gut and are fermented by bacteria producing gas, which actually causes bloating, intestinal distension, and abdominal pain. Examples of high FODMAP diet are like milk, wheat, onions, apples, and artificial sweeteners. We have to avoid these kind of food, and we have to eat more of vegetables, fruits, and proteins. So, coming to the main part, that is the psychological therapy. Earlier, it was mainly used for psychiatrical problems and children with obvious psychological severe problems having functional abdominal pain. But the current studies shows that CBT is not only used as a supportive role, but it is the mainstay of management. For example, in CBT, children are taught to identify pain triggers, change their negative thoughts, develop coping strategies, and reduce the pain of fear. For example, if a child believes whenever I eat, my stomach will hurt, then this causes fear of meals and avoidance of eating. But in cognitive behavioral therapy, the therapist actually gradually exposes the child to eating while teaching their coping strategies, like starting with small meals, encourage positive thoughts, teaching relaxation during meals. This actually gradually makes the child to eat without causing any pain. This actually breaks the pain fear cycle. The next therapy will be the hypnotherapy, which involves the deep relaxation and guided imagery. Here, three techniques are used, like, for example, balloon relaxation technique. For example, the therapist asks the child, your stomach is a very tight balloon. Now, slowly imagine the balloon is relaxing and becoming soft. This imagery actually helps the brain to reduce signals that increase intestinal muscle tension. The second example will be the river flow visualization. The therapist actually asks the child to imagine like food moving through the intestine like a calm flowing river. This imagery actually help normalize gut motility patterns. And third example will be about the warm light relaxation. A warm light spreading throughout your abdomen so that the relaxing the stomach and intestine. This reduces the visceral hypersensitivity, stress related gut activity. Why the hypnotherapy works actually, why is that hypnotherapy influences the brain areas that actually process the brain, anterior cingulate cortex, insula, brain pain pathways. So this leads to reduced pain perception and improved gut motility and reduced stress response. um, uh, Now, usually in earlier sessions, it was only cognitive behavioral therapy was available only in person therapy sessions. But now it is actually available as online platforms, mobile apps, and web based modules also. Coming to the pharmacological part, earlier the treatment was focused on mainly on relaxing the intestinal muscles. Like we give antispasmodics and anticholinergics like dotavirin, mebavirin, and hyoscine, which actually works by blocking calcium entry into the smooth muscle cells and reducing intestinal muscle contraction. But current treatment part mainly target is gut-brain axis. So there are drugs called as neuromodulators. For example, amitriptyline and fluoxetine are used. Amitriptyline works by increasing the serotonin and norepinephrine in the brain, activating the descending and inhibitory pain pathways, thereby reducing the transmission of pain, improving sleep, and reducing anxiety. Earlier, the management was mainly with the pediatrician. The main role was given to the pediatrician alone, but the modern management involves a multidisciplinary team approach, which involves pediatrician, gastroenterologist, psychologist, and dietitian. For example, if a 10-year-old child comes with a recurrent abdominal pain, here the pediatrician evaluates the child and confirms there is no organic disease. Gastroenterologist identifies that the child has a functional abdominal disorder. Psychologist discovers that the child is stressed because of school examination and provides cognitive behavioral therapy to manage stress. Whereas the dietitian finds that the child consumes large amount of FODMAP diet and advises dietary modification. So the outcome will be the best. So multidisciplinary team approach is the best, and this is what the recent updates also tells us. So this is the flowchart showing if a child comes with chronic abdominal pain, we have to take history and examination, check for any red flag signs. If there are any red flag signs are present, we have to investigate further for organic diseases. If there is no red flag signs, then we have to look for a minimal test like CBC, fecal calprotectin, and celiac screening according to the recent advances. If it shows normal results, we have to go with the diagnosis of functional abdominal pain disorder and treat with multidisciplinary approach. Thank you. These are my references.
Thank you, doctor. A very nice presentation. As you rightly said, when evaluating a case of a chronic abdominal pain, the physician's role is to identify whether the child has got a disorder of brain gut axis or due to true organic pain. So look for the red flag signs like your growth fault, which is very important. Monitor the growth is very important, or there is a deceleration of the growth or growth faltering, presence of anemia, presence of any rashes, organomegaly, unexplained, like your weight loss, involuntary weight loss in adolescent age, and any family history of IBD. All these things should be taken into consideration when analyzing case. Once you rule out only that there are only no red flag signs, is only a disorder of brain gut axis, then you classify the pain according to that syndrome, whatever you have seen accordingly, as you earlier mentioned. So basic investigations, what she has said, you have to do that. And in North India, we do see a lot of celiac cases. So celiac cases may be one of the cause of chronic abdominal pain in North. However, in the South, we do rarely see, but we have to think when they come from, because we have a lot of even North Indian families settled in South India. So try to get that history. The manifestations may vary. The most important, what she said, is also about the diet. Child taking a lot of a high FODMAP diet, taking a lot of your carbonated drinks, taking a lot of milk, paneer, whatever that produce a lot of gas that can cause your lactose or bloating and cause dyspeptic symptoms. So diet history is very important. Look for the red flag signs. As aptly rightly say, any pain away from the umbilic is always organic. Just get the history focused on the site of organ involvement. Try to rule out the organic causes. Then you take the all your consideration, put them the classification, which group am I dealing with, plot the growth, and basic investigations as and when required, tailored investigations do it. And she rightly said, doing fecal calprotecting is of now to differentiate between IBS and inflammatory bowel disease. IBS is, as she said disorder of brain gut axis. The fecal calprotectin is a cytosolic neutrophilic protein which migrates to the area of the gut where there is inflammation. So it differentiates between the IBS versus inflammatory bowel disease, but does not differentiate between IBD versus your infectious disease of the colon. Even acute dysentery, any inflammation can produce increased fecal calprotectin, but calprotectin will not be elevated in IBS, irritable bowel syndrome. So that is a screening marker that has come into one of the criteria. Not to differentiate. Next, she also said the basic pathology. It's not the The normal pain is perceived because of the reduced pain threshold, because of the reduced, altered brain and what you call gut dysbiosis, some amount of inflammation, and altered your dietary fiber, whatever it is. So focusing on this concept, she has beautifully said the pathophysiology. So she also mentioned, having discussed, this is not an organic cause, not what next to do. So multidisciplinary approach is very important. You need to have the basics. So the pharmacology comes only next, not the first. So it is a behavioral therapy, cognitive therapy, hypnotherapy, psychotherapy, and taking care of the dietitians and psychologists, general pediatricians, a primary caretaker, then with the gastroenterologist. So she is nicely focused. Where are we? Just chronic abdominal pain is not a single disease. Sometimes you need to have a multidisciplinary approach to tackle at the multiple levels so that you can have a best, whatever the result we expect for the child to have. So that is very important. The most important cause of chronic abdominal, don't forget to get into the detailed history of the bowel. Chronic constipation, functional constipation is the most important cause of chronic abdominal pain still in our country. Okay, I think we'll discuss later. So it is a multidisciplinary therapy, focus on the diet, the low FODMAP diet, avoiding the triggers, identifying what is the stress in the child, and try to help the child in coping with the stress so that to have a best outcome, to have a pain relief. Thank you, doctor. So the focus, please note about the gut dysbiosis, altered brain-gut interaction, what is the pathophysiology, and what is the multimodality therapy, and what are the red flag signs to differentiate your dysfunctional pain or the disorder pain of due to brain-gut interaction. So these are the disorders. No longer it is called as a psychogenic pain or a dysfunctional chronic pain. Thank you, doctor. Very nice presentation. Any doubt in chronic abdominal pain? So the investigations should be tailored based on the symptom. Investigation should be done as and when required, not all routinely doing all the investigations. And pharmacotherapy, depending upon the underlying etiology, plan the therapy and give the drugs. Okay, this is very important. Dr. Lakshmi, any comment you want to give, Dr. Sudhakar?
That was an excellent presentation by both the students. I think hats off to the mentor, ma'am. It shows such
They have done
succinct
their best.
presentation, so much clarity. I think the reason why this topic was selected is because it is so innocent. It looks so innocent, but
Yes.
so many complex connotations. It's not all black and white. I think that's the point Sumati ma'am wanted to drive in today. And one very important point which Sumati ma'am said, which I would like to reiterate is constipation. Remember, the most common organic mimic of functional pain. So I think let's remember that point. And at the outset, I would like to use this opportunity to also thank the head of the departments of the respective medical colleges, the students who are participating today. Thangavelu sir from Mehta, Sasikumar sir from Coimbatore Medical College, Kumaravel sir from Salem, and Selvakumar sir from Tanjavur Medical College. I would really like to thank all four of them on behalf of Team IAPCCB.
Yes,
so let's move on. Can we move on, ma'am, to the next topic?
Yes.
Okay, so the next topic, here it is. So it is constipation. Now, why is there such a hue and cry about constipation? Because remember, constipation is actually a symptom and not a disease. For this reason, the precise definition has always remained elusive. But for practical purposes, we do have a consensus in the terminology. So today we have two students who are going to, demystify constipation, bust myths, and give clarity about the definitions, approach, diagnosis, and treatment. So may I request first Dr. Vishnupriya to start the introductory session, part 1 of constipation. Dr. Vishnupriya, can you start sharing your screen?
Yes, ma'am. Are you able to see my screen, ma'am?
Oh, no. Yes. Yeah, we are able to see. Yeah, proceed.
Good evening, everyone. So, starting with the constipation. So, functional constipation defined as persistently difficult, infrequent and incomplete defecation in the absence of any evidence of primary anatomic, pathological, or biochemical cause. So it accounts for about 95% of all cases of the constipation in healthy children above the age of 1 year. So what is normal stool frequency in age less than 1 month is 3 to 4 stools per day. In 1 month to 1 year is 1.5 to 2 stools per day, and 1 to 2 years is 1 to 2 stools per day, and more than 2 years, 1 stool per day. So according to Rome criteria, the must include 2 or more of the following occurring at least once per week for a minimum of 1 month, with the insufficient criteria for the diagnosis of IBS. So it includes 2 or fewer defecations in the toilet per week in a child of developmental age of at least 4 years, at least 1 episode of fecal incontinence per week, history of retentive posturing or excessive volitional stool retention, history of painful or hard bowel movements, presence of large fecal mass in the rectum, large diameter stools which can obstruct the toilet. After an appropriate evaluation, symptoms cannot be fully explained by another medical condition. So history taking plays an important role in the constipation, which must include the age of onset, passage of meconium, stool characteristics like amount, frequency, consistency, painful defecation or blood streaks, retentive postures, urinary symptoms, which may tell about the coexisting urinary tract infections or voiding dysfunction. So history must focus on growth and development milestones and history of withholding in order to differentiate functional constipation from organic causes. So most common symptoms in chronic constipation, of about 70% of the children have straining during defecation, hard stools, abdominal discomfort, bloating, infrequent bowel movements, and feeling of incomplete evacuation. We have the BSFS scale for the has type 7, 7 types of describing of the stools, which helps in assessing. The new terminologies for chronic constipation is divided into 3 categories based on the mechanism, like normal transit constipation, slow transit constipation, and defecated disorders or rectal evacuation disorders. Slow transit constipation is by reduced colonic motility, delayed colonic transit on imaging, and poor response to pharmacologic stimulation during motility studies. It is represented by type 1 and 2 in BSFS scale. And the defecated disorders have uncoordinated rectal contraction and paradoxical anal sphincter contraction or incomplete relaxation during defecation. Any new onset constipation, we should rule out about organic or secondary constipation causes. So the red flags in constipation, we should think if there is any short stature, delayed development, lethargy, cold intolerance, think about hypothyroidism, delayed passage or failure or delayed passage or failure to pass meconium, failure to thrive, abdominal disease, think about Hirschsprung's disease, any tuft hair, abnormal neurological findings, think about spinal dysmorphism, significant perinatal history, delayed development, feeding abnormalities, regression of acquired milestones, think about cerebral palsy, neurodegenerative diseases, recurrent respiratory tract infections, failure to thrive or meconium, think about cystic fibrosis, or any unintentional weight loss more than 10% in 3 months, rectal bleeding not due to fissure or hemorrhoids, family history of colon cancer, family history of polyposis syndromes, also familial adenomatous polyposis. The pathogenesis, fecal continence is mainly maintained by the internal and external anal sphincter, by the involuntary and voluntary control, perianal muscle contractions. Defecation urge occurs when stool enters the lower rectum. When the child refuses to defecate, there will be withholding behavior by tightening of external anal sphincter, which leads to contraction of gluteal muscles. Later, stool is pushed back into the rectal wall and decrease in the urge to pass stool. And the child will be exhibiting this by common withholding maneuvers like refusing to sit in the toilet, standing on toes, crossing legs, screaming or turning red, which is usually misinterpreted as behaviors to attempt to defecate. So prolonged stool retention leads to increased water absorption from stool. Formation of hard or large stools, which with passage of hard stool causes painful defecation, which may lead to blood in streaks or anal fissures. So this will lead into a vicious cycle: pain of defecation, voluntary withholding, prolonged fecal stasis, increasing in size and consistency, aggravation of pain. Usually the precipitating factors will be diet, any stressful event, forceful toilet training, postponing of defecation. With chronic stool retention, liquid stools may form the proximal colon, may leak around the impacted stool and lead to fecal incontinence. So chronic complications of untreated chronic constipation may lead to enuresis, recurrent urinary tract infections, urinary symptoms, rectal prolapse, pelvic dyssynergia, and rectal bleeding. These are my references. Thank you.
Nice presentation. So she has said the definition of constipation, that is a difficulty in passing stools causing significant distress. So large caliber stools, hard in consistency, causing significant distress with retentive portion is typical of a functional constipation. The most common cause of constipation in children is always functional, more than 95%. Less than 5% will be organic. But however, a good physical examination is a mandate step to differentiate amid dealing with functional constipation versus a organic cause.
Not
So,
audible, please.
examination.
Not audible, please.
Am I audible now?
Yes, ma'am.
Yeah.
Yes, you are audible, madam.
Yeah. Good physical examination is the first step. You have to differentiate, am I dealing with a functional constipation or a organic. 95% is always a functional constipation. The characteristic withholding behavior starting usually after 1 or 2 years and large caliber stools. This is typical of their functional constipation. These children, when they have this chronic constipation for longer time, they can just present with diarrhea, what is called a spurious diarrhea. It's not a true diarrhea. Don't forget to get the history. A simple rectal examination can give a clue. Is a true diarrhea as a chronic diarrhea or due to diarrhea due to chronic constipation. But head-to-foot examination look for dysmorphic facies, fluoride, hypothyroidism, Down syndrome, and characteristic. All the examination signs, even for neurological examination, look for the perianal area, look for any cremastic, whatever the reflexes and anal reflexes, tone of the muscles. If the child is abnormal, to rule out some of the rarer causes of your neuromuscular causes that can present constipation in children. Never to miss all those rare conditions. And mechanism is very important, as she said, to not to miss Hirschsprung disease. Hirschsprung disease, you know that delayed passive meconium, necrotis enterocolitis, passive blood and mucus diarrhea, failure to gain weight, abdominal distension, and when you just do an parallel examination, there will be gush of feces on withdrawal. Rectum will be empty. In contrast to functional constipation, if you just do a clear examination, the rectum is loaded. That is typical of their functional constipation. It's not organic. So no need for investigations in 95% of cases, but in 5% may require. And she rightly said, what are the different types of your constipation? Slow transit versus your normal transit, and pelvic floor dyssynergy are the defecation disorders. This slow transit constipation, you should not give high fiber diet because the symptoms will be even worse. But normal transit constipation, you can advise high fiber diet. And the other category require your manometric studies when they are not responding to your conventional therapy of laxatives, when they present with whatever is a fecal impaction, you have to just disimpact, then you have to put them on maintenance. So examination is very, very important. Head to foot examination is very important in a child with functional constipation, not to miss even less than 5% for organic causes. No investigations are required. A simple abdominal examination, look for the fecal mass. If the child is cooperative, that is enough. The child is uncooperative, you can just take a plain X-ray abdomen for the loaded colon. Because adequate disimpaction is the first important step in treating a child with constipation. I think the pathophysiology she has mentioned. So child with megarectum indicates the constipation for a longer time. So this child will require laxative for a longer time because the rectum has all the muscles have lost its whatever it knows, so tensile strength. So it takes a longer time for them to show the response when they give laxatives, and the minimum period may even extend beyond 6 months. You have to tell the mother. And then when they present with this soiling of undergarments, you tell the mother not to withdraw the drug at the earliest because they can have the relapse of the symptoms and they require drugs for longer time as well. Next presenter, I think they can take up the management.
Good evening, everyone. So,
Yeah.
first of all, I would like to sincerely thank IAT CCP branch for giving me this opportunity to present in this recent updates program. I would also like to express my sincere gratitude to Dr. Sumati ma'am for constantly guiding us throughout this preparation. So, moving on to the presentation, today I'll be presenting recent updates in the diagnosis, evaluation, and management of functional constipation in children. So, the presentation will mainly focus on 5 main areas: prevailing guidelines for functional constipation, recent updates in the diagnosis and evaluation, key difference between the older and the recent concept, overview of treatment strategies, and what are the new advances in the management of functional constipation. So, constipation is one of the most common pediatric gastrointestinal disorders. Evidence-based guidelines developed by ESPAN and NASPAN aim to standardize the evolution and management of constipation in children. So, based on this guideline article by Tabas et al., Rome 3 criteria has been used in the earlier days for the diagnosis of constipation. Next slide, please. So this Rome 3 criteria has been used in the earlier days. Now, however, newer updates have modified certain aspects of these criteria. Rome 4, as per this article, recently Rome 4 criteria, which has been introduced later, refine the diagnostic approach. So this is the, as discussed earlier, this is the Rome 4 criteria which has been used now, which is being used now. The main difference between the Rome 3 and Rome 4 criteria lies in the duration in the diagnosis of treatment. Next slide, please. So, yes, as I said, in Rome 4 criteria, the duration for the diagnosis of symptom, that is constipation, has been reduced from 2 months to 1 month, which allows a slightly earlier diagnosis. Also, the terminology has also been changed from functional GI disorders to disorders of gut-brain interaction. Also, in Rome 4 criteria, it is now said that abdominal pain and or bloating may occur, but they are not the predominant symptoms. That is, the criteria for IBS should not be met, supporting the concept that functional constipation and IBS may coexist on a continuous spectrum. So also, a greater emphasis has been made on symptom-based diagnosis. Rome 4 stresses a stepwise evolution, that is, detailed history, clinical assessment, and basic tests like CBC, thyroid function test, serum calcium as indicated. Also, colonoscopy should be done only in the presence of alarm symptoms like unintentional weight loss or any family history of colorectal cancer. So, in cases that are refractory to treatment, physiological testing such as colonic transit study, anorectal manometry, balloon expulsion test, and epicography can be done, but they are reserved only for refractory cases. But they should not be done routinely. Treatment mainly emphasizes. Moving on to the treatment, it mainly comprises of 5 main components: parental counseling and education, adequate diet and hydration, behavioral therapy, encouraging physical activities, and finally the pharmacotherapy. Parental counseling should be mainly focused on the pathophysiology of constipation. Next slide, please. So, as discussed earlier, presence of hard stools in the rectum produces painful bowel movement, which leads to voluntary withholding of feces by the child, which in turn leads to presence of stools in the rectum for a prolonged time, which leads to more painful defecation, which in turn leads to megarectum, as said by ma'am. This leads to habitual and chronic constipation, as megarectum leads to reduce the rectal sensation. So, parents should be advised to encourage their child to defecate within 30 minutes of the major meal in order to utilize gastrocolic reflex. Parents should also be encouraged to ensure adequate fiber intake, that is 0.5 gram per kg per day. Adequate hydration and regular physical activity should also be encouraged. So, pharmacotherapy mainly comprises 2 main sections, that is disinfection followed by maintenance therapy. Identification of fecal impaction and disinfection with laxatives is an important initial requisite for subsequent effective maintenance laxative therapy. So, mainly there has been 2 methods for disinfection: home-based disinfection and hospital-based disinfection. In home-based disinfection, polyethylene glycol can be used at a dose of 1.5 to 2 gram per kg per day in 2 divided doses for 3 to 6 days. When used in hospitals, it should be used at the dose of 25 ml per kg per hour, perorally or NG or through NG tube over 4 to 6 hours. In case if these methods fail, rectal agents can be used for disinfection. This should be followed by maintenance therapy. For maintenance therapy, osmotic laxatives such as polyethylene glycols and disaccharides can be used. Polyethylene glycols should be used only in more than 1 year of age. It should be given at a dose of at half the dose that is used for disinfection, that is 0.5 to 1 gram per kg per day. Bloating, abdominal pain, vomiting, and loose stools are its side effects. Disaccharides such as lactulose and lactitol can be used. Lactulose for infants 2.5 ml BD, and 1 to 5-year-old child 2.5 to 10 ml BD, and 5 to 18 years old 5 to 20 ml BD can be used. In general, disaccharides will cause abdominal distension and discomfort. So, regular painless defecation, successful toilet training, and no fecal soiling or blood in stools is the these are the criteria for successful treatment. So parents should be encouraged to maintain a stool diary to track progress and improve compliance. So tapering should be done. Laxative should not be stopped abruptly. It should be tapered only after 2 to 3 months of successful treatment, and it should be gradually reduced over the next 2 to 3 months. Rescue therapy, mainly stimulant laxatives, should not be used as a maintenance therapy. It should be used only as rescue therapy in case of acute constipation while on maintenance therapy. So, this article by Sakshi Gupta et al. Indicates the importance of posture in chronic constipation. Sitting posture, that is in Western toilet, is significantly associated with constipation. Squatting posture straightens the anorectal angle and facilitates easier stool passage. In case of using Western toilets, footrest can be used to maintain that anorectal angle, thereby reducing constipation in children. So another study by Brian E. Says that polyethylene glycol is superior to lactose and effective in long-term use. In case of patients who are refractory to conventional treatment, newer secretory agents can be tried. A chloride channel activator, lubiprostone, has been introduced in the market, which can be given at a dose of 24 microgram twice daily. It increases intestinal fluid secretion and improves stool frequency and consistency. The common side effects include nausea and diarrhea. Also, guanylyl cyclase agonists like linaclotide and plecanatide has also been newly introduced. Linaclotide is being given at a dose of 145 microgram OD. It improves stool frequency, straining, and consistency. A new emerging drug, elobixibet, has been still under development. It is an ileal bile acid transporter inhibitor. It increases bile acids in colon and improves stool frequency. So also regarding diet, conventionally, general dietary fibers was recommended for constipation. Recent RCTs RCTs have evidence of using specific fruits like prunes and kiwi fruits, which improves stool frequency and constipation symptoms. So in general, early diagnosis, proper treatment, proper counseling, and evidence-based management has been shown to reduce constipation in children, thereby improving the quality of life of children. Thank you, everyone.
Thank you, doctor. Very nice presentation. So she rightly said how to manage a case of your childhood constipation. Whenever you see a child with constipation, make sure it's only functional by ruling out other organic signs by clinical examination. Once it is functional, the first step is to look whether the child has got an impacted stool or not. Child has got fecal impaction, you have to adequately disimpact. During that time, you can even give a short course of rescue therapy along with polyethylene glycol if there's loaded, rectum is fully loaded. And polyethylene glycol is the drug of choice for disimpaction, can be used even for maintenance laxative. And once it is adequately disimpacted, child should be put on maintenance laxative either with polyethylene glycol or lactulose or even the lactitol. And in infants, we go for lactulose therapy less than 1 year, and polyethylene glycol for older children is a safe drug and is the best drug for disimpaction. Once disimpacted, you have to put them on maintenance along with the dietary fibers, regular follow. The mother, the parent should be instructed not to stop the drug at an earlier date, because the most important cause of refractory constipation is always a early withdrawal of the drug. Adequate disimpaction, adequate maintenance dosage along with dietary therapy and toilet training. That is very important. The child should be made to sit in the best is the Indian toilet. When they are using the Western toilet, the mother should be instructed to use the footrest. If they are not to, like they should not hang the foot on the toilet when they are sitting on the Western toilet. Adequate pressure should be mounted so they can ease the bowel. That is very important. And you have to make use of the gastrocolic reflex. Everyone will have, some many of them will have when they eat food or even when they take some coffee, whatever it is, they feel urge to defecate. That's called a physiological gastrocolic reflex. This should be taken into beneficial in part of treating a child with childhood constipation, to tell the mother to give something to eat and fix up the time, the same day, time of the day, the same place. The child after giving something to eat should be sit in the toilet for half an hour at least 20 to 30 minutes regularly. That is called a toilet training. That is very important. Okay. And because nowadays we do see even constipation occurring in the early childhood because of your artificial formula or the non-breastfed babies, and even coercive toilet training even before the month of 18 months, before the age of 18 months. So all these things should be avoided. And once the mother has been advised a diet and the regular usage of laxatives with the frequent follow-up, that is very important. Once you put the drug, you have to tell the mother to come for regular follow-up because you have to look for the response. And once they respond only, you have to stay for the drug and then slowly stop the drug. Minimum period is at least for 3 to 6 months. Early withdrawal is the most important cause of your refractory constipation unless proved otherwise. Okay, so diet plays an important role, and activity. Physical activity is also very important in children with constipation. And refractory, anybody is taking a refractory constipation?
No, ma'am, you can touch
Yeah.
upon it, ma'am.
Refractory constipation, by definition, not responding to adequate dosage of drug, the good choice of drug, even after 12 weeks, you have to think of refractory constipation. In practice, the most important cause of refractory is always the early withdrawal of the drug. That's very important. Once you rule out all these things, make sure the drug dosage is adequate, the choice of the drug is adequate, then you have to send the child for further evaluation. And ultra short segment Hirsch can mimic functional constipation, hypothyroidism, and children like even some of the metabolic disorder, hypercalcemia, and anorectal, pelvic floor dyssynergia, that we have to make sure only by manometry. Once you prove this, you can put the child on regular behavioral therapy and along with the laxatives, and it may take a longer time. And the most other important cause, like even slow transit constipation. You have to prove that only by using a radiopaque marker study that is available in some of the centers. When you just ask a patient to swallow the radiopaque marker, and after 5 days, you have to count the number of radiopaque markers. Suppose the markers are present throughout, not getting evacuated even after 5 days, it is called a slow transit constipation. Sometimes one segment of the bowel will have the radiopaque markers because segmental inertia. You have to classify. In such conditions, you cannot advise a mother to give a lot of fiber in slow transit constipation. So these are some of the conditions for refractory constipation. Apart from that, child with cerebral palsy, neuromuscular disorders, some of the endocrine causes, or local pathology involved with the pelvic floor muscles can have refractory constipation. In such conditions, you have to go for some of the like therapy like antegrade enema. We just do a cecostomy, give the enema, or retrograde enema along with this. So refractory constipation is a distinct entity. It needs referral for further evaluation, but rule out this. Still, it is only functional constipation. You make sure whether mother is giving the drug adequately, adequate dosage, along with the diet and toilet training. That is very important. Okay. So the newer drugs, what she mentioned, is on the pipeline, and many of the adults we are using, but not in children. But in older children, you can use drugs like prochloropride and even tegasteroid, and the newer drug, like bile acid inhibitors. It is on the, it is mainly they are all used in the adult, but probably in future maybe used for children. Okay, so these are the drugs that are in the pipeline as well. So any doubt?
Thank you so much, ma'am. So very well explained. I think I have a question for you, ma'am.
Yeah.
Since the new definition, the Rome 4 criteria in toilet trained children, we consider at least one episode per week of incontinence after the acquisition of toileting skills as constipation. So can you explain for the benefit of the postgraduates how constipation progresses to encopresis if left untreated? Just the physiology.
Yes, yes. See, in constipation, what happens? There is, the child has got a painful defecation. So, child tries to withhold the stool, not letting the stool out. So, when the stool stays in the rectum for longer time, more and more water is absorbed. So, it becomes more dry. So, next time the child will have pain during defecation. So, every day the same phenomena continues. So, the rectum will enlarge because of the larger amount of stool getting built up in the rectum. So the rectal muscle loses its tensile strength, and even the sensitivity is also less. So whatever like stools in the proximal colon, which is very watery, will leak around the solid motions rectum and come as spurious diarrhea, and sometimes even present as encopresis, causing soiling of the undergarment. When there is soiling of undergarment, it indicates the problem is there for longer time, and it's a megarectum is there, and they may require laxative for longer time because it doesn't require, they will not respond within 3 months. You have to tell the mother because, and longer time is needed for laxative therapy along with the diet management as well.
Thank you so much, ma'am. I think if we were to sum this up in 2 words, I think I would be right if I said it is defective propulsion
Yes.
and defective sensation in the megarectum.
Yes.
Okay. Okay, ma'am. One more question. What is the Espagan and the Naspagan's take on digital rectal examination in constipation?
Yeah, digital examination is not recommended usually, even by the Nespagan, even the Espagan. So, like palpation of abdomen will do. And if you have a child is not even allowing, if you want to make, you can just take a plain X-ray abdomen. But in practice, when you can explain the older children what is the procedure, you can do that. You can use the little finger for infants with adequately lubricated. I can just do once when they come for the first time. It's not contraindicated, but you should do it gently after explain the procedure. But if you feel the mass per abdomen, no need for a digital examination. And if you feel any loaded colon on plain X-ray, no need for that. And digital examination role only to rule out any Hirschsprung disease especially. So they do not recommend routinely.
So clearly said, ma'am. So I think the 2014 recommendations do not support performing a
Yes.
DRE
Yes.
in functional constipation, and nor do the position statements recommend laboratory testing barium enema in the absence of alarm signs. So are we right in saying this?
Yes.
Okay.
We don't do barium enema for routinely diagnosing constipation. Only when we have a doubt to rule out Hirschsprung disease, only we do barium enema. Even then, when you're doing barium enema, you should not do when they are on laxatives, because we may miss a proximal, what is dilated segment, the distal spastic segment, and narrow transition zone will be missed. So your child should be off laxatives when you're doing barium enema, number one, only to rule out Hirschsprung disease, not to diagnose functional constipation. Another role of barium enema may be to diagnose any rectal stricture. Otherwise, no need, routinely, not done. And manometry is a gold standard for your Hirschsprung disease. And finally, no, it is proven by the biopsy, which is ultimate diagnosis made by full thickness biopsy, not the mucosal biopsy. You cannot ask for a colonoscopy biopsy to diagnose Hirschsprung disease. We cannot diagnose that. The surgeons can take a full thickness biopsy to diagnose Hirschsprung disease, which is a gold standard ultimate diagnosis. Yes.
Thank you so much, ma'am. I think it's just pearls of wisdom. So if I may take the liberty of summarizing, so functional constipation is a symptom criteria-based diagnosis. So history and red flags guide workup. We have clear red flags, say onset before 1 month of age, delayed passage of meconium, or bloody stools without anal fissure, severe abdominal distension, growth faltering, neurological signs. And early aggressive treatment is associated with the best prognosis. And I think education and consistent routines are just as important as medication. So I think we had a wonderful session with a wonderful mentor, Sumati ma'am, and 4 enthusiastic postgraduates. So if I may request Sumati ma'am to turn on her camera, and also the 4 postgraduates to turn on the camera. Let's all see your faces. The enthusiastic students, we would like to see the presenters. They have done a very good job.
Thank you, Dr. Sudhakar, Dr. Lakshmi, all the 4 chiefs of the various departments of different medical colleges. When Sudhakar asked me, I said, okay. I said, it is, I think initially he thought it's chronic constipation. Then he said, no, madam, chronic abdominal pain. Then we combined both the topics. I said, we can take both the topics as well. And the postgraduates have done a very fantastic job. Within a short span of time, I just gave the articles to them. They have read it and made it very nicely with beautiful presentation, very crystal clear and very crisp. Congratulations, all the my dear postgraduates. Once again, I thank Lakshmi, Dr. Sudhakar, and all the members of the IAPCC branch. And because I too feel very happy to be with the students. Thank you, Dr. Sudhakar.
Yeah, thank you, madam. Thank you, madam. Really, it's very satisfying and proud of ourselves of initiating these recent updates in pediatric education, because many times we have a case presentations and routine things are happening all over the year.
Yes,
so we want to touch the initiative recent updates. I have to thank Dr. Balasubramaniam sir coming out with the idea of chronic abdominal constipation. In the beginning, I thought why it is a very common subject, very common thing. Now only I realized why he has selected this topic actually. Very practical, I'm sure. Most of the practitioners would have made use of it actually. Excellent presentation by the thing, and just because of the articles. And I'm very happy to see the students quoting the articles and latest updates in. hats off to you, my postgraduates, and I thank all my teacher, Dr. Tangavelu sir, and my three friends, Dr. Sasikumar, Dr. Komaravil, and Dr. Selva Kumar, all the HODs of pediatrics for preparing the students actually. And I thank Dr. Lakshmi for anchoring and everything, taking care of each and every step. Thank you, Lakshmi. Thank you, IAPCCB team. Thank you, sir.
Thank you,
Thank
Dr.
you, sir. Thank you. So with that, we come to an end of the second session. Please remember that all these sessions are live streamed on YouTube. The recordings are available. You can check out our first session on HLH. This session will be available. It's on YouTube channel, our IAPCCB official channel. Please subscribe to our channel and also stay tuned for updates that will be posted in the CCB official channel and also connecting the BUDS group. We have several programs for you lined up. Please enthusiastically participate in the Golden Jubilee Pedicon quiz as well. We have interesting questions every day, and the winners will be awarded in the final conference. May I request Sudhakar sir?
Yeah, one more thing to add. This is the 50th TNSC Golden Jubilee Pedicon for State Pedicon. Please enroll yourself, register yourself. It's going to be a very mega event with academic feast, and it is the 25th year of Chennai City branch. So please join us for that, and please read Countdown Chronicle, which is being prepared by Dr. Lakshmi and myself. The main person giving the content for that actually. I'm giving designs out for that actually. Okay, it's a teamwork. Finally, please read Countdown Chronicle as well as the what. And next program will be the research update assistant program. So fourth Thursday we will be coming out with research assistant for postgraduates, and again it is a short crisp discussion on the research topic itself. So I welcome all students to join that also.
Thank you so much, sir.
Thank you
So if
everyone.
that will be all, I think I will finally wind up the session. A big thanks to Sumati ma'am. Big thanks to SBS sir. A big thanks to all the EB members of the Chennai City branch who have joined. Thanks to the enthusiastic audience, the postgraduates, the teachers, the head of the department, and everybody who made today's session a great success. Very interesting. So until we see you next time, this is the Chennai City branch signing off. Good night.
Thank you. Thank you. Good
Good
night.
night. Good night. Good
Night.
night.